uh, with long-standing hypertension and diabetes, presents with elevated renal function tests, EGFR tisarilo, urine analysis shows mild proteinuria with hematuria. She is on enalapril 10 milligram nocte and metformin extended release 500 milligram BD. What is the most appropriate management? Okay, so she is having long-standing hypertension and diabetes with elevated renal function, worsening, deteriorating renal function, right? And this patient is having urine analysis shows mild proteinuria and hematuria, right? So she seems to be having some kind of nephritic syndrome, nephrotic mixed picture. What is the most appropriate management? Now this is a recent onset elevation of renal functions. So what is this, acute kidney injury or chronic kidney injury?
Acute.
Acute.
Okay, how do you define acute and chronic kidney injury? I will discuss this in the MCQs. I can remember. Yeah, so acute kidney injuries, according to KDIGO, if there is reduced urine output less than 0.5 milliliters per kilogram per hour for more than 6 hours, right? Or if there is increase in serum creatinine levels, right? Or blood urea nitrogen levels. I can't remember. I think it was 1.5 times within 24 hours or 12 hours, right? So that is how we define acute kidney injury. So this patient has had acute kidney injury, and he seems to be having nephritic with nephrotic mixed picture, right? So now, when a patient with acute kidney injury presents to you, depending on the EGFR, I have already told you that if the EGFR is less than 45, right, milliliters per kilogram per cubic meter, you cannot give certain drugs. You cannot give SGLT2 inhibitors, right? And you cannot start metformin newly. However, if it goes less than 30, you need to remove metformin, right? Okay, so what do you need to do now in this patient, in the drug chart?
Stop metformin. Oh, no. It is 38. SGL. Oh, that is.
We cannot include this.
Did we stop metformin?
Yeah. Ideally, we need to stop metformin. And also, we need to stop enalapril, right? Okay. So there is a thing now in CKD patients. What is the best drug to control hypertension? Enalapril, excellent. But why now CKD patients, if they are on hemodialysis also, best drug to control blood pressure is enalapril. In hemodialysis, usually the serum creatinine level is something like 3 point something. EGFR is something like 10. So why can't you give metformin? Why can't we continue enalapril here in this patient? No, because this patient is having chronic kidney disease. If it is acute kidney disease, you need to stop. Understood?
Wait, can you say again?
Yeah, so now CKD patients, they are having chronically low EGFR, no?
Yeah.
Those patients you can have enalapril continuously used, right?
Okay.
However, if the patient suddenly develops a deterioration of renal function acutely, right? That is acute kidney injury. There you need to reduce the drugs, right? Especially you need to reduce the enalapril. Understood?
Okay.
Because that is acute onset renal injury. In that scenario, if enalapril is used, there is very high risk of hyperkalemia and complications, right? Okay. Metformin you need to reduce in a patient who has already who is on metformin if the EGFR is less than 30, right? Okay.
Okay.
So the answer here with the given information would be to stop and print. Understood? Okay, so we go to the next one.
Yes. Okay.
43-year-old woman with advanced CKD presents with dyspnea, oliguria, nausea, and vomiting for 2 days. Investigations follow the following. Serum creatinine is sky high, right? Sodium level is high. Potassium level is morbidly high, right? Then calcium level is this. Hemoglobin level is very low. pH level is also very low. Now, what is the most important parameter that should be addressed first? Anyone?
Hyperkalemia.
Vale?
Hyperkalemia.
Acidosis. Anything?
Acidosis. Yeah.
No.
Hyperkalemia.
Hyperkalemia. Acidosis correct කරේ නැති වුණත් පොඩි වෙලාවක් patient ඉන්න පුළුවන්. But if you don't correct hyperkalemia, this patient will get lethal cardiac arrhythmias. Will go into cardiac arrest and they will die. Understood? So always correct the hyperkalemia first. What are the cutoffs for hyperkalemia? Normal cutoff is 4.5 to 5.5 to 6 is mild hyperkalemia. 6 to 6.5 is moderate, and more than 6.5 is severe. Right? Severe is impending cardiac arrest. Here, high risk of ventricular tachycardia or ventricular fibrillation. Understood? So this patient is having moderate hyperkalemia. Are the
Hi.
36. 34-year-old bank executive presents with shortness of breath on exertion, daytime sleepiness, lethargy, and snoring at night. What does this sound like?
Obstructive sleep apnea.
Yeah, excellent. Okay. Both his parents have diabetes, right? BMI is 35. On examination, he has acanthosis nigricans, right? What does acanthosis nigricans suggest?
Diabetes.
Insulin resistant.
Okay. What is this BMI? Overweight, obese, morbidly obese.
Morbid level.
This is morbid obesity. Blood pressure is 130/85. Fasting blood sugar is elevated or normal? Normal.
Normal, no.
HbA1c is normal. AST and ALT are both elevated. Lipid profile increased triglycerides and LDL with low HDL. Okay. And then ultrasound scan, grade 1 fatty liver. So what is the condition he is having? Hello? He's having muscle. Metabolic syndrome associated with steatotic liver disease, right? Okay. And he also seems to be having metabolic syndrome. But we need to, what are the criteria we need to diagnose metabolic syndrome? Basics, we need to know this. Anyone?
Abdominal circumference.
No.
Waist circumference. No, you don't measure that.
Yeah, there is circum. So 3 out of 5 criteria need to be there, right? One thing is the waist circumference, right? And the other one is triglyceride levels, hypertriglyceridemia. Then low HDL levels, and then blood pressure or hypertension. If it is hypertension, you need to consider this patient as metabolic syndrome. Fasting blood sugar levels. If the patient is having fasting blood sugar glucose more than 100 milligram per deciliter, which is not diabetic but in the impaired glucose tolerance range, according to the ADA cutoffs, right? If 3 out of 5 of these are there, the patient has metabolic syndrome. What are the complications of metabolic syndrome? Ale? Anything else? Increased cardiovascular death risk. Anything else? Mm. Any others? These are the common ones. Huh? So, what is the best step to improve his metabolic status? A. Commencing on moderate dose of metformin. Commencing on SGLT2 inhibitor. Prescribe GLP-1 agonist. Prescribe therapeutic lifestyle with 5 to 10% weight reduction. Prescribe moderate dose statin. Yes. Usually, however, this lifestyle modification is not very effective for a patient with BMI more than 30. හරිද? ඒ කට්ටියට අර ගැස්ට්‍රෝ මේ ඒ කට්ටියට surgery එකක් කරන්න. They need to undergo gastric bypass surgery. හරිද? But out of the answers given here, this is the only one we can choose, right? We cannot choose moderate statin, right? Then other ඒකට බැරි වෙන්න හේතුවක් තිබ්බා. Moderate statin එකක් දෙන indications තිබ්බා. Just give me 1 second. I'll quickly go through my phone and go through the answers to that. That's a good question actually. ඒකට විනාඩියක් දෙන්න. I'll quickly discuss that. Right? Okay, we'll go to the next one. A 32-year-old woman presents with recent onset weight gain of 12 kg despite a normal diet. She has recent onset amenorrhea. On examination, she is thin with purple stripe. What is the diagnosis here?
Cushing?
Okay, what is the diagnostic test for Cushing's syndrome?
24 hours urine. High dose.
High dose dextrose. Pituitary. Central Cushing's hari.
අපි කතා කරන්නේ නේද? ඔව්.
Diagnostic
නෑ.
low dose එක තිබ්බොත් low dose එක ගන්න එක හොඳයි high dose එකට වඩා. Oh. But here out of these given answers බං මේක තමයි ගන්න වෙන්නේ. What do you use 24-hour cortisol levels for? That is for screening, not for confirm. Petrosal sinus sampling. This is to identify whether this is coming from the pituitary or this is a pituitary Cushing's. Right? What are we checking in the petrosal sinus sample? ACTH. The petrosal sinus cortisol එන්නේ නැහැ නේ. ඒක ඔළුවේනේ තියෙන්නේ. ACTH suppression test එක ACTH level එක නෙමෙයි ACTH level එකෙන් මොකද කරන්නේ? What do you check?
Adrenal Origin. Yeah.
Yeah, whether it is central Cushing's or peripheral Cushing's.
Peripheral.
If it is central Cushing's, ACTH level will be increased or decreased? Increased. Excellent. CRH level at 8 a.m. is not done. Na? Cortisol level. CRH level same balance. So this is also cortisol level at 9 a.m. is a screening test. So out of the given answers, this is the one we can take. High dose dexamethasone operation test. Understood? Right. Okay, so Cushing's or diagnostic the use of each of these investigations you need to know. You have identified this pattern. Okay, so we go to the next one. 70-year-old man presented with generalized malaise and back pain for 3 months duration. Investigation show the following: serum ionized calcium levels is increased, right? Phosphate is decreased. Right? ALP levels is increased. Serum creatinine level is relatively normal. What is the most probable diagnosis? Right? So, what is the phosphate level here? Reduced. Calcium levels normal, but I will find and give. Or 2.2 to 2.7 kg. So this is low. Okay. So ALP is high. So what is the diagnosis? Now in hyperparathyroidism, will the calcium levels be increased or decreased? Or मैं पढ़ना है एक तमा වැදගත් calcium level. ඒ කියන්නේ calcium ඒක කීයද? Alright, 1.325. 0.5 to 1.3. එතන මේක normal ද? නෑ මේකෙත් තියෙන 1.16 කියලා. So මේක low වගේ නේ. ඒ කියන්නේ calcium වල serum values ගත්තොත් එහෙම, if you think about the serum values of calcium, there are three calcium values. One thing is ionized calcium. Ionized calcium කියන්නේ free calcium. This free calcium is actually what is important for all the feedbacks, right? Important calcium level for feedback mechanisms. Understood? And then there is also bound calcium. That is calcium bound to calcium binding proteins. The calcium binding proteins, what happens is the calcium molecules are sometimes bound to albumin, right? So this ionized calcium and free calcium together is known as total calcium. Understood? Right? එනකොට අපිට වැදගත් වෙන්නේ PTH hyperparathyroidism the disease එකද කියලා බලන්න decide කරන්න mainly at our level the ionized calcium level. Understood? Right? So what is the most likely diagnosis කියලා අහන්නේ? So tertiary hyperparathyroidism, will the calcium levels be increased or low? Increased. Primary hypoparathyroidism, will calcium levels be decreased or low? Decreased. Phosphate levels? Increased. The hypoparathyroidism.
Decrease.
Or decreased. Sorry, increased. Sorry. Osteoporosis will not cause any abnormality in the calcium levels, right? මම කියවන osteoporosis කියන්නේ bone density එකේ වෙනස. ඒකේ මොනවද serum calcium level ට කිසිම වෙනසක් බලපෑමක් ඇති කරන්නේ නැහැ. So we can remove this. Osteomalacia. Osteomalacia වලදී කියන්නේ it's like vitamin D deficiency. What happens in vitamin D deficiency? There is reduced calcium levels and phosphate. That is possible, no? Yeah. Right. So this is a possibility. Osteomalacia. Tertiary hyperparathyroidism, no. Because there will be ectopic calcium secretion, PTS secretion, and increased calcium levels and reduced phosphate. Hypoparathyroidism, no. Okay. Because phosphate levels will be increased. So it has to be Paget's disease and osteomalacia, right? Okay. They know the utterate abelian. Right? Out of this, you can notice that the ALP levels is very high. What is the disease that causes increased ALP levels? Out of these two, both will cause increased elevated ALP, but what is the one that causes increased ALP, very, very high ALP levels?
Paged.
Yeah.
Paged.
Is the one that causes very, very high elevated ALP. So that is why you need to choose this. Paget's disease is an abnormality in the bone formation. There is bone formation abnormality. So what happens is the bone is not very good quality. The bone is not very good quality, so it increases the bone remodeling. It increases the bone remodeling and it increases bone formation. In abnormal weak bone ගොඩාක් හදාගෙන යනවා. Right? එතකොට ඒ වගේ කට්ටියගේ bone එක quality එකක් නෑ. ඒ නිසා fractures වල ලොකු chance එකක් තියෙනවා. ඒ වගේම තමයි because of the poor bone, because of the increased turnover of the bone, they get back pain and different pains in the bony regions of the body. Understood? මේක කියලා දෙන හැබැයි ඉන්ටර්නෙට් එකේ නම් abnormal levels may indicate calcium and phosphate levels are usually normal. Osteoporosis වල abnormal කියන්නේ osteoporosis වල වැඩි වීමක් වගේ. Osteoporosis වලදී bone density එක අඩු වෙනවනේ. Paget's disease එකේදී bone density එක වැඩි වෙවි යනවා. හැබැයි ඒක abnormal වැඩි. Essentially, there is accelerated bone turnover with subsequent rapid new bone formation. This bone, however, does not have normal bone matrix. Bone increases in size but is more brittle and prone to fracture. Understood?
Yeah.
So, I think osteomalacia is also a possibility here. Let me check from another side as well. So this is a good document. The reason that I actually chose Paget disease, the other reason is because this is an old patient. Paget's is very common in old individuals. Okay. Paget's is very common in old individuals. Oh, ඒක තමයි. Hmm. Yeah, I think this is most likely gadgets or osteomalacia එකත් පුළුවන්. But just know the differences. මේ osteomalacia වල තමයි calcium උයි phosphate level දෙකම අඩු වෙන්නේ කියලා තියෙන්නේ. So I'll check this in the Umaran clock also and check and give you guys an answer. Okay. It has to be either pellets or osteomalacia. That's what we need to remember. Understood?
Yes.
So we go to the next one, 39. A 34-year-old woman consumes alcohol regularly, presents with low-grade fever, lethargy, and loss of appetite for 1 month. She is pale, icteric, and has bilateral cervical and axillary lymphadenopathy and moderate splenomegaly. WBC count is increased lymphocytosis. AST ALT levels are also increased. And the total bilirubin level is increased. Right? Indirect count is 4.2. So is this indirect or direct hyperbilirubinemia? Indirect. And then here they have mentioned that is also IgG positive. Right? Okay, so what is the if the direct Coombs test is positive, what is the diagnosis? I told you this. Coombs karaddi positive one, what is the diagnosis? Autoimmune?
AIHA?
Yeah, hemolytic anemia.
Anemia.
Okay, so this patient is having increased lymphocytes. What of these conditions lead to autoimmune hemolytic anemia with increased lymphocytes?
Lymphoma.
One answer. And does this compatible with the picture? Icteric, bilateral, cervical, and axillary lymph node with splenomegaly. True or false?
True.
Remember, lymphoma commonly causes cold type autoimmune hemolytic anemia, right? Okay. මේකත් commonlyම කීපවතාවක් අහලා තිබෙ MCQ වල. අහලා තිබ්බද නැද්ද?
Arunaja, what did you say? I got cut off. Can you repeat?
Yeah, so lymphoma commonly causes cold type autoimmune hemolytic anemia.
Okay.
And this patient, though he's alcoholic, she's having bilateral cervical and axillary lymphadenopathy, which is generalized lymphadenopathy. And then there is also moderate splenomegaly, right? Okay. So if those features are there, it has to be hemolytic anemia in the background of generalized lymphadenopathy. The diagnosis has to be lymphoma. Okay. Okay. Did you do the most important thing is not that, but do you guys remember that this kind of question was asked in the previous papers?
Yeah, right.
Yeah, 2 to 3 times I think asked.
They ask so much about lymphoma in this like MCQ or this like SBR like where the answer is lymphoma. I don't know.
Right? Olivens and venos in the පුළුවන්. ඇයි this can be related to lymphoma or unrelated to lymphoma. It's an alcoholic patient, so it can the patient can have underlying fatty liver disease also. Also, if the lymphoma actually invades the liver, it can cause damage to the liver, and that can release enzymes. Okay. So in this patient, both can be a cause. Okay, so next one. 42-year-old female presents with fever and seizures. She is confused with a body temperature of 38 degrees Celsius. Neurological exam is otherwise normal. Blood pressure is 160 by 100. Blood hemoglobin level is 5.6, so there is reduced hemoglobin levels. Platelet count is 20,000, reduced or increased?
No,
Reduce ne?
it is on the lower level side. No, not
Low level
increase.
ne?
I
Sure.
mean,
That is the normal
150 is.
hemoglobin, normal platelet count. 150,000.
150 ne?
Oh, it's a 20,000. Okay, reduced.
Reduced, yeah. Serum creatinine level is also very much increased. Schistocytes and polychromasia. What is the diagnosis now? This is a MAHA. You get schistocytes only in MAHA, microangiopathic hemolytic anemia, right? It is most likely due to DIC or other related conditions. Now, what are the conditions that lead to MAHA that present with hypertension and fever and seizures? And also increased body temperature. That is what you need to identify. So, what do you think is the diagnosis? Hmm? Does TTP cause
TTP
hypertension?
ne?
Maybe Evans syndrome. No.
Yes, that is Evans syndrome. Okay.
And can you please tell something about it? I just wild guessed it. I don't know why.
So TTP, first we'll identify what TTP is. TTP is this. So there is this in the body, right? The 1 Willebrand factor is removed in the body by this protein called ADAMS-T3, right? In TTP patients, ADAMS-T3 is not there. So 1 Willebrand factor activates platelets abnormally and you get MAHA, right? So these 1 Willebrand factor activates and then in the blood vessels you get MAHA and DIC. Okay, that is TTP. Okay. TTP related. So often occur, so this is what happens, right? Okay, so now in TTP, this is what happens. However, in TTP, usually you don't get hypertension. A fever then on. Let's see what Evans syndrome is. Evans syndrome is also very close to this TTP. Oh, oh. ඒ කියන්නේ Evans වලදී වෙන්නේ DIC එකක් එන්නේ නැහැ Evans වලදී. DIC එකක් එන්නේ නැහැ. MAHA එකක් එන්නේ නැහැ. Okay. In Evans you don't get MAHA. You do not get MAHA. So in Evans you do not get MAHA. It is just autoimmune hemolytic anemia with reduced platelets. Okay. Yeah. So now ITP කියන්නේ ITP කියන්නේ මම ඕනම ටික විතරක් කියන්න. හරි. ITP කියන්නේ immune thrombocytopenic purpura. හරිද? එතකොට ඒ කියන්නේ immune reaction එකක් හින්දා, ඒ කියන්නේ immune autoimmune cause එකක් හින්දා the platelets reduce in the body. හරිද? එතකොට මේක present වෙන්නේ platelet reduction එකක් ආවොත් එහෙම the patient will usually have bleeding and this bleeding will be in the skin, and then also in the mucosal surfaces. So, if this patient develops this kind of bleeding and you detect reduced platelet counts, it has to be ITP unless ITP, right? It can be ITP. However, ITP is a diagnosis of exclusion. You cannot diagnose ITP just directly. When all other causes for platelet reduction is removed, you can diagnose ITP. So what happens in ITP is that you get the platelets, no? And to these platelets, antibodies bind, right? No one knows why these antibodies are formed in the first place, but some people think that it is due to a response to an infection, and due to molecular mimicry, sometimes these antibodies are formed, and these antibodies get attached to platelet membrane proteins due to molecular mimicry, right? So due to this, what happens is the platelets are destroyed in the spleen. Okay, so because of that, the platelet counts reduce. But you need to remember, in ITP, there is never splenomegaly. හරිද? Splenomegaly තිබිලා platelet අඩු වුණොත් it is not due to ITP. Okay, that is one thing. And the second thing you need to identify is that in ITP there is never reduced hemoglobin counts and reduced WBC counts. In other cell lines are not affected. Isolated platelet අවුලක් තමයි එන්නේ. Okay. හරිද?
Right.
Right? And the other thing is, splenomegaly නැති වුණාට ITP patients can have lymphadenopathy. හරිද? Okay. So, and the next thing is the reduction of platelets. The reduction of platelets has to take place when there is no feature of infection. හරිද? ඒ කියන්නේ ඉන්ෆෙක්ෂන් එකක් ඇඟේ තියෙනවා කියලා අපිට පේද. දැන් patient කෙනෙක් ඩෙන්ගි හැදලා ඉඳිද්දි ෆීවර්ත් එක්ක platelet count අඩු වෙද්දි that is due to the infective response, cytokine storm, not due to ITP. So the patient cannot have any infections also. මේ ඔක්කොම criteria fulfill වෙනවා නම් තමයි ITP diagnose කරන්න පුළුවන්. හරිද? එතකොට ITP වල duration එක අනුව you can divide ITP patients into two parts. One type is acute ITP and the other type is chronic ITP. හරිද? Chronic ITP කියන්නේ usually patient की platelet counts reduce වෙලා තියෙනවා more than 3 months duration. හරිද? Acute ITP කියන්නේ එකපාර disease එකක් ඇතිලා usually within 2 weeks විතර platelet counts අඩු වෙලා තිබිලා within 2 weeks platelet counts pick up වෙනවා. More than 3 months සාමාන්‍ය platelet counts අඩු වෙලා තියෙන්නේ නැහැ. එතකොට chronic ITP patient ලට we need to treat. Why? These patients have increased chance of bleeding. Which type of bleeding they can get? Commonly, increased risk of GI bleeds and also increased risk of intracranial bleeding. Either. So, in chronic ITP, treatment is usually immunosuppression. Okay, because we need to suppress the immunity to remove the antibodies and to keep the platelets working. And the other treatment for ITP is to stimulate platelet production. එතකොට මේ විදිහට තමයි ITP වල treat කරන්නේ. Usually acute ITP වලට no need for treatment, no need for acute treatment. You only need to treat in emergency. හරිද? ඒ කියන්නේ patient platelet transfusion එකක් එහෙම දෙන්න වෙනවා acute bleeding එකක් આવොත්. ICH එකක් හරි නැත්නම් GI bleeding එකක් આવොත් patient ඒ වගේ වෙලාවට platelet දෙනවා නැත්නම් no place of platelet transfusions also. හරිද? No platelet transfusions are done. තේරෙනවද? right? එතකොට දැන් chronic ITP patient කෙනෙක් આવොත් එහෙම immunosuppression විදියට යාට දෙන්නේ usually IV prednisolone. හරිද? IV methyl prednisolone දෙන්න පුළුවන්. නැත්නම් අපිට දෙන්න පුළුවන් IV rituximab. හරිද? නැත්නම් අපිට දෙන්න පුළුවන්. ওই වගේ ඒවා තමයි දෙන්නේ. හරිද? නැත්නම් oral dapsone දෙනවා සමහර patient. හරිද? platelet වැඩි කරන්න අපිට දෙන්න පුළුවන් treatment එක තමයි මොකද්ද L thromboplaque. L thromboplaque කියන්නේ අර මේ erythropoietin වගේ thrombopoietin කියලා තියෙන්නේ. අන්න ඒකේ මේ synthetic drug එක. හරිද? එතකොට ඇඟේ platelet synthesis එක වැඩි වෙනවා. හරිද? තව මෙයා acute crisis එකක් ආවොත් ඒ වගේ වෙලාවට antibodies අයින් කරන්න අපිට IV plasmapheresis උත් කරන්න පුළුවන්. හරිද? එතකොට මේවා තමයි ITP මොකක්ද diagnosis එක diagnosis වලට නම් තියෙන්න ඕන the criteria that has to be fulfilled. What is acute ITP, chronic ITP, and management of chronic ITP? And this is all they will ask. Share them. So this patient has to have TTP, not Evans. Evans already in autoimmune hemolytic anemia and ITP combination. So next we go into the next one. 23-year-old female with background history of SLE presents with cough for 1 month. On examination, there is stony dullness over the right lower zone with reduced breath sounds. Investigation shows leukopenia, anemia, thrombocytopenia with high ESR and CRP. Chest X-ray confirms right-sided pleural effusion. Best investigation to diagnose the cause. Okay. 23-year-old female. Background history of SLE, cough for 1 month, stony dullness over left lower zones with reduced breath sounds. Investigation shows leukopenia, anemia, and thrombocytopenia. So what is this? All 3 cell lines affected. Pancytopenia, right?
Pancytopenia.
With high ESR and CRP. What is the next best investigation to diagnose the cause? So what are the differentials for this presentation? Ale? What are the reasons for a SLE patient to come with respiratory distress and increase the ESR and CRP? One thing is that. How can CRP increase in SLE flare-up? I thought it was usually ESR. But if there is pleural involvement, pleuritis, pleural effusion එකක් තිබ්බොත් එහෙම CRP වැඩි වෙන්නත් පුළුවන් SLE වල. හරිද? And then this can also be due to parapneumonic effusion, something like TB or a chronic pneumonia. Right? What are the other differences? So now what is the best test to diagnose this condition? Blood pitch එකෙන් අපිට අලුත් දෙයක් ගන්න පුළුවන් නේද? බෑනේ. මොකද මෙයාගේ blood pitch එකේ already counts ඔක්කොම අඩුයිනේ. ඒ කියන්නේ underlying consolidation එකකට එහා පැත්තෙන් effusion එකක් එනවා. Pleural fluid analysis එකෙන් පුළුවන්ද අපිට? Yeah, so it is a bit difficult to do. Right? So what is the next best investigation to do? Yeah, we can do either this or anti-double strand DNA. What is the best one?
Anti-double strand DNA?
Yeah, this is more specific for SLE flare. So we can identify whether this is SLE flare. Why do we need to identify whether this is SLE flare or infection?
For the treatment?
No, the treatment is completely different. If this is SLE flare, what is the treatment? Ale? If we do immunosuppression for infection, what will happen? Patient will die, sepsis and death. So we need to give IV antibiotics for this. So 2 different causes. So we need to identify the two causes separately from each other. For that, anti-double strand antibody levels are the best. Okay. So they come usually adeno. Oh. Oh. So this is how you differentiate infection and a flare-up in a SLE patient. C3 and C4 they come adeno, right? Raised anti-DNA DNA. अब infection එකදී usually dsDNA elevate වෙන්නේ නැහැ. Okay. හරිද? හරිද? So shall we call it today?
Okay, madam. Thank you very much, ma'am.
Thank you. Good
Thank you,
night.
ma'am.
Okay,
Good night.
Good night.